Both from the UK. Our first speaker is Dr. Neil Houston, who's a GP and also National Clinical Lead for Healthcare Improvement Scotland. And he's going to be talking to us today about safety improvement in primary care.
Okay, thanks very much for asking me to speak. I'm a clinical lead for developing a safety programme for primary care, and I'm also a GP, and I work in a town called Dollar, which is backs on some hills, and behind my house is a castle called Castle Gloom, and on the other side of the castle is a burn called Burn of Sorrow, and the other one is Burn of Care. So thanks very much for helping me get out a wee bit. So the aims of the session really are to, I suppose, engage with you about why safety is important in primary care, to share some developmental work that we've been doing around about safety, and then talk about our emerging national programme for safety in primary care. This is our beloved leader, Alex Salmond, who is pushing for Scottish independence. We're not there yet, but we do have devolved responsibility for health. So we have our own policy for NHS Scotland, and a key difference from compare that with NHS England is we have a quality strategy which has identified that the key priorities of quality are around about patient-centeredness, effectiveness and safety, and we've got some fairly high-level aims around about no avoidable harm and giving all patients evidence-based consistent care. We have a patient safety programme, but that up till now has been exclusively acute focused, although there is spread into mental health and paediatrics and primary care. But why should we bother about primary care in terms of safety? Isn't all the harm done in hospitals? But I would recommend a literature review done by the Health Foundation, which, if you catch them after this, have done a very good literature review of safety and harm in primary care and how can you improve safety. So I would really recommend that to you. And they came out with some concluding statements. Was that the adverse event rate in consultations is between 1% and 2%. That doesn't mean there's always harm from an adverse event, but there is suboptimal care. That the evidence would say that about 8% of admissions are due to suboptimal primary care, and that the patients at most risk are those frail elderly patients with multiple conditions, multiple medications, who attend in and out of hospital and practice. So I think the key thing about primary care is its scale. 90% of work done in primary care, that 300 million consultations in the UK, 1 or 2% adverse rate. They conclude the absolute number of those harmed may be just as large or greater than secondary care. Some other research has looked at patient-reported harm in primary care, and they have recorded an adverse event rate of 8 times the 1 to 2%. So where does harm occur? Well, it comes from drug adverse events, medication errors, delayed diagnosis and clinical area. I think areas of poorly performing systems for handling results is a crucial area of potential harm. And GP practices and primary care teams, there's lots of administrative systems within practice because they are very complex organisations, and when things go wrong, harm occurs, and communication is clearly always there as a cause of error and harm. Other statistics, 11% of prescriptions in the UK contain errors. If I'm in a care home, I have a 1 in 2 chance of having an adverse drug event in every year. And there's a whole, with this increasingly elderly population and multiple medications, we are at greater risk of having some high-risk prescribing. I'll just share this graph with you. So every line is an individual practice, and the vertical axis is the proportion of patients in that practice who are on warfarin who are also receiving a non-steroidal. So some practices, nobody, but in 1 or 2 practices, or in this practice, every 3rd patient on warfarin is a non-steroidal, which is not a good combination. Sorry. Okay. So the bars on the right-hand side represent practices who have got a very high percentage of their patients on warfarin, also on non-steroidals. And we have a lot of data in primary care that can help us identify areas of harm. Other statistics, 12% of patients on methotrexate in the health board in Scotland were not being monitored. Patients are meant to receive just 1 strength of methotrexate, but almost a third were receiving 2, and in some cases it wasn't prescribed weekly. So we harm patients by doing things to them, and we harm patients by not doing things to them. I think one of the real dangers in primary care is the harm that we do by not doing things to people. And although we're very good at auditing individual elements of care, when we look at patients such as this group who we have quite a high, this is from my own practice, where patients on any inhibitor we score quite well. If they're on the correct beta blocker, they score quite well. We're not very good at getting them up to the right target. We give them a vaccine and we record their NYHA breathlessness status. But actually, if you look at the number of patients who receive all 5 interventions, that's only 5 interventions out of a possible 8 or 9 for heart failure. Less than a quarter are getting reliable care. And NICE has done some work in the UK where it's looked at diabetic care, and again, a similar picture where less than 40% of patients are receiving key interventions if they have type 1 diabetes. I mean, beyond all that, I think that primary care has had a lot of emphasis on safety, though we've not called it safety. We've got real strengths and significant event analysis. We review our complaints. We have well-developed IT systems. We have good prescribing systems that flag up alerts. We do know that results go missing, and practices have developed systems for managing results fairly effectively, and many practices do have a good safety culture. So we got money, again, recognising the Health Foundation, to develop some approaches to improving safety in primary care. So we worked with 50 primary care teams to do a number of things to identify and reduce harm, to improve reliability of care in key areas where the care was felt to be risky and suboptimal. So that was patients on DMARDs, that's methotrexate and azathioprine, patients on warfarin, and patients with heart failure. Develop the practice safety culture and start to involve patients in quality improvement. So members of practices were brought to learning sets, so we had a collaborative. They learnt about safety and harm, about human factors, about reliability, and then they went to their practices to collect data and to start to perform some change. So the tools we used were bundles, which we've developed, trigger tools to look for harm, safety climates, and to promote patient involvement. I'm going to talk about the top 3 in a bit more detail. So from all this was to say, are the topics we've chosen right? Are the tools that we've developed, are they appropriate? If we are wanting to spread within Scotland, what should we spread and how to spread? So key to it is measurement. How many people are familiar with care bundles? So quite a few of you, but hasn't really been used that much in primary care. But for those who aren't familiar, it's about 4 or 5 elements of care which are evidence-based. The elements of the care are across the patient's journey, and through that it creates teamwork, and if it's done reliably, improves care. And rather than the old audit, which was measuring things in lots of patients at the beginning, perhaps having an intervention and then measuring them at the end, it's this small, frequent samples and seeing which patients are receiving all elements of care. So this is an example of a bundle that we developed for patients on azathioprine and methotrexate. So have they had the full blood count down the past weeks? If there was an abnormal result, was it acted on? Has the blood test been reviewed? Have they had a pneumococcal vaccine? And are we asking about side effects? And this just shows the improving reliability with this bundle. The reason it drops is that we actually adapted the bundle and we added the patient measure in just when it gets to sort of 75%. So it dropped down, and then practices took that on board and took that into their bundle and their care. An example of our Warfarin Bundle, which is basically looking whether the warfarin is prescribed according to guidance. Has the patient been taking the right dose? Have we been taking the repeat blood test at the right time? And have we been giving them face-to-face education? So then we were asking practices to collect data on five sets of patients per fortnight, and again looking at an all-or-nothing measure. And this is the composite measure for 10 practices over a few months, just showing that compliance with the bundle has improved. So in evaluation, practices were saying the care bundle was useful. It identified gaps, and it did provide real focus for improvement in patient education, but also in their practice systems. Just let you read that. So again, the advantage of bundles, regular measurement over clinical audit, which is not a rapid process. I think the other interesting thing is that actually the practices were involved in almost half the number of the INRs that were being carried out. So that actually by doing things reliably, by all partners following guidance and all clinicians following guidance, you actually increased capacity. Now I'd like to talk a bit about case reviews, as a way of looking at case reviews to look for harm. So this chap, David Gray, is a gentleman in the UK who died from an overdose of morphine from an out-of-hours doctor. So we all hear about that, but what we don't hear about is the harm that's lying underneath the surface. So how do we look for that? So I'll just take you to South Africa, to the Kruger National Park. So if I'm looking for lion in the Kruger National Park, I could drive up and down for days and never find any lion. But if I go to a watering hole, I'm more likely to find lion. And on the way, I might find some water buffalo. But if I look for where all the other cars are, I'm much more likely to find lion. So in the same way, if you're going through patient records looking for harm, you could spend all day looking for harm and not find any. So we've developed a trigger tool, which practices were asked to review 20 sets of records of patients who were either had heart failure, were on warfarin, or methotrexate, and look for the previous 3 months for these triggers. Probably can't read them, but it's things like, have they had more than 3 consultations in 7 days? Have they had a new read code? Have they had a new allergy code added? Have they attended out of hours? Have they been to hospital? Have they had a low or high INR? And have they low hemoglobin or a reduction in the EGFR? And you look for the trigger, and then you look at the notes and see if harm has occurred. You then rate it in terms of severity, and you look and find out where the harm occurred. Was it secondary, primary care, or was it indeterminate? And was it preventable? And at the bottom, you collate your findings, and you also look for incidental findings. So that's the water buffalo. You go looking for harm, but actually practice started finding lots of other things as well. So from that, the 20 sets of records, you were then encouraged to reflect on what you found and then decide what to do as a practice team with that. And the experience has been very positive on the whole. Quotes has been overall very positive. It's been a fantastic tool. It's quick. We have a maximum of 20 minutes per record, but many just take a few minutes. They're finding harm, the sorts of thing they were finding where patients being given a drug that they previously hadn't had a reaction to and re-given it. Patients who are on a high-risk combination of drugs who have ended up with a gastrointestinal bleed, and lots of kind of coding and systems error, and lots of incidental findings as well. And that's then provided a focus for improvement, but also has led to cultural change. But the caution would be that practices need training, and many of them need support, and it's not for measurement. I know in the acute sector they've used it for measurement, but for primary care, reliable measurement over time would be just too difficult. But it's missing the point. It's actually an incredibly good tool for improvement. So safety culture, clearly important. This is what primary care sometimes feels about secondary care and vice versa. Sometimes what happens when things go wrong. So we have developed and tested a safety climate survey in practice. The practices fill it in online. They get their own report, and it compares the practice's climate survey with all other people in practice that have filled it in. And interestingly, it also compares clinicians against non-clinicians' perceptions of climate, and also managers as opposed to non-managers. And so it's used for measurement, but it's also used as a real tool and a catalyst for change, to have those difficult conversations. So I think practices have found it useful. Interestingly, the steering group thought this was in the too difficult box when we did it in first year, and we were going to actually abandon it, but the practice and the evaluation said this is crucial because this involves the whole team, and it allows us to have that discussion, and it's really important that you carry on with this. We have evaluated it fairly intensely. We have the measures. We've had interviews of practice staff. We've had interviews of the steering group. We've had impact questionnaires. And that has actually informed the programme as we've gone along. So after a year, they give us some very useful feedback, which we then use to adapt the programme. So some successes were practice reported improved patient care. They have adapted and changed their systems. They felt they had more knowledge skills around patient safety. It had an effect on culture. It improved team working. Patient involvement was starting to happen, although practice found it really difficult. And then when they did it, they said, why haven't we done this before? And I think the other thing was practice reporting and evaluation that has actually made their systems more efficient. So what were the challenges? There's always challenges. So for some, it was about understanding what the tools were about. For some, it was about time pressures. For some, it was about competing priorities. it was really difficult for the people at the learning set to come back to the practices and involve their whole team. And I was part of the program, and you can imagine the investment I had in the program to make it work in my practice. And it was very difficult to get everybody on board. People talked about resources and remuneration. Practices were just given some backfill money to come and attend the learning sets. And clearly the practices where the culture was not well developed, where the environment was not conducive to discussions and the ability to reflect on your practice, made it more of a challenge. Outcome measures and these things are challenging, and so we see that a change in the perception of climate as an outcome measure, the idea that we should see an improvement in INRs within range as a result of this, and over the long term see an admission with heart failure. So we're currently looking at that data. And I think if we find that things like the INRs within range hasn't changed, then we need to be developing and changing the things we're measuring. So again, it's like all these things, it's something that's actually in a work in progress. So how is this spreading? Well, in fact, what's interesting is that lots of practices on boards in Scotland are coming and saying, we've heard about the tools, we want to try them. In our own board in Forth Valley, we are asking practices to collect data around warfarin and DMARDs and changing their contracts, so they're required to do that to drive improvement. But I think in the back of all this is that Scotland has committed to design and implement a patient safety programme in primary care, and that's from rollout from 2013. So what I just wanted to do was just tell you a bit about what's going to be in that programme, and that'll be it. So, I mean, I think one of the great things is that primary care is huge. So where do you start? General practice, community pharmacy, community nursing, dentistry, optometry. So initially we are starting with general practice, district nurses and community pharmacy. That's still quite a big chunk of the mammoth, but we feel that's probably the best grouping and where the most knowledge is, and that will move on to develop other elements of the programme. So there's 3 themes, and they're around about safe and reliable prescribing, monitoring and administration of high alert medications. So I've talked about DMARDs, I've talked about warfarin. We're developing measures for and interventions to help district nurses administer insulin more reliably and safely in patients' homes, because that's been flagged up through reporting systems as being an area of harm, and lithium clearly is another fairly toxic drug. We're looking at giving practices that sort of high-risk co-prescribing data that I illustrated, and giving them to practices and get them to reflect on that and think about what they might do about it. And medication reconciliation is well known as an area where risk occurs and harm occurs, and a poor medication reconciliation leads to readmissions. And the National Patient Safety Programme for Scotland in the acute sector is working on MedRec, but clearly they can't fix it without involving primary care as well. The other theme is around about the safe and reliable patient care across the interface and at home. So we're looking at management of test results. So WHO have identified test results and poor follow-up of test results a major cause of harm to patients. And I think there's evidence from the Medical Protection Society that has done a number of risk assessments in practices, and they report that 85% of practices feel that their systems for managing results are unsafe. They don't track results in and out, they don't find out which bundles are missing, they don't necessarily reliably act on them, so there's huge potential for improvement and change. We're also looking at communication at the point of referral, and I've talked about medication reconciliation. We have done some testing work in test results in MedRec, where we got 5 practices from a board to come and meet with an element of the acute sector. And what was really interesting was they all turned up to sort out the other bit of the system. So they're in this kind of room about process mapping, so we're going to sort you out. And then by the end of the afternoon, they actually said, what we need to do is sort out our bit of the system, and then we can work together on this. So actually having people from primary care and secondary care just sitting in a room, doing some process mapping, identifying where elements of harm was incredibly powerful. So we've developed measures for these that practice can collect to see whether their systems are reliable. Other things, we're looking at reducing harm for vulnerable, frail elders in the home care setting, so looking at falls, pressure ulcers and catheter-associated UTIs. So we're just developing that work, so I'd be very keen to know from anyone else in the room whether they've done any work in this area, so that we can learn from you, because this is an area that is currently in initial stages of development. I think a key thing is about, the third theme is about promoting safety culture and leadership. So we're using trigger tools, climate surveys. We want to trial safety walkarounds within practices, so the executives from the board coming down, talking to staff, hearing about their safety concerns. And again, I think that would be very good to get high-level buy-in. I think a lot of it's about developing skills and knowledge of practice staff and also board staff, because our experience would be that boards need to support this work actively. They need GP clinical leadership, they need quality improvement leadership to help support practices. And I think another crucial thing is about having patients becoming partners in making care safer. If I'm a patient and I'm having some blood taken from me and I don't know what happens next, or, I'm not being used properly as a safety net if I don't know what the processes are, or what the expectations of my role or the practice's role. So in that and in any management of systems, I think if we can develop the patient's role, I think that's absolutely crucial. So this is how it feels sometimes, because it feels a bit lonely, and it also feels like quite hard work, because we're not importing some work that's been done elsewhere currently. We've been doing a lot of the heavy lifting ourselves. I think we have been working with the early adopters, so the challenge is how do we work with 100% of practices. But I think clinicians do buy into these topics and this approach. I think they're a bit tired of changing people from one drug to another to save a bit of money. But if you talk about perhaps looking at your systems to make them more reliable, to make them more efficient, if you can make sure that medication list that comes from the hospital is a bit more easy to understand, if we can make sure the results don't go missing, then that makes our lives easier. At the end of the day, we want patients that are happy and safe, and we want to go to bed at night, sleep well, and when you're away on holiday, you don't worry what you're going to come back to. Thank you.
Thank you, Neil. We can take some questions from the floor. Do you want to use the mic? Yeah.
Hi, I'm Claire Gordon. I'm from Scotland as well. I wondered how this linked into some of the QOF stuff we're doing, because obviously whenever I've sort of thought about some of the ideas that they do in places like Kaiser Permanente about having panels and checklists and bundles, the GP colleagues I speak to in Edinburgh say, oh, it's all done by QOF, stop worrying about it. Whereas you seem to have focused on some other areas. Do they work well with QOF, or do some GPs just feel it's
well, I think practices found that using the bundles really highlighted areas where they thought their care was reliable. I mean, I think if you are going to make it across all practices, I think it will have to be reflected in the GP contract as one of its levers. And I think we're having some discussions on Tuesday about what's possible about that. I think the other area, another driver, is around about revalidation and appraisal. So in Scotland, every person has to have an appraisal each year, and all the evidence that the tools we've evidenced around about trigger tools and climate surveys and bundles are evidence that you can use, that clinicians can use for revalidation. So I think if we can make sure all these things can address a lot of their agenda, lots of different agendas, then we'll have more chance of seeing it spread. But I think that still doesn't underestimate the amount of support that practices need. They need to be trained and learn about safety and reliability, and so we need to use all the resources that are there.
Yeah, hi Neil, my name's Jeff Fuller from Australia. I'm interested in spread, and I'm not sure whether I just sort of missed it, but particularly spread to other areas of primary care, home nursing organisations and so on. Are you able to say, in a sense, what's the 3 dot points that are enablers and barriers to spread, that being the uptake of new practices to get involved in patient safety?
Well, I think for safety, one of the barriers is there a problem? So, people probably think that their systems are pretty safe and reliable, but so one of the things is around collecting data. It's the same as in collaboratives and chronic diseases, that until you start collecting data, you're not going to realise that there's a problem to be fixed. But that's then has to be balanced by, raising alarm with patients and so on. So, one of the things is in terms of how do we communicate that message and how do we engage. And we've got some very powerful videos and useful approaches that can do that. And now we've got some champions that can go and stand up and say, when I was here 2 years ago, I was a real skeptic. And, now I see that there's lots of things to be done. These can be really useful to achieve the things that many people within practice perhaps have wanted to do for a while and issues they wanted to raise.
G'day, I'm Kyle from New Zealand. There's been very few studies done in primary care on trigger tools, and I'm just wondering whether you've validated your tool at all that you're using.
It has been validated, yeah, by NHS Education Scotland, yeah. I mean, I think we've had a discussion about, in terms of an outcome measure for the national programmes, could we say that we could do a 30% reduction in harm, but you actually need to be able to measure that. And the person who developed the trigger tool and has had it validated, he has looked at the logistics of it, and if you're going to have a reliable system for measuring over time in 1,000 practices, you'd need to be doing hundreds of thousands of records on a regular basis. So, I think we started thinking of it as a measurement tool, but ended up thinking it as a real driver for improvement and culture change.
Mary Ellen Benzik from the United States. Question about your safety videos. Are those for patients or for other providers?
They're for clinicians.
Okay,
yeah.
Because I think that's where we're really challenged. How do you send up this red flag to patients without totally freaking them out? And if you've had a lot of success with that.
Well, I mean, maybe I could briefly talk about what we did with the patients. It was quite interesting. We clearly, on every element of every bundle, we had a patient element of it. So it was about patient education and asking about side effects and so on. And then we, with the health boards that were recruited, asked to recruit a group of patients to come from each practice who had warfarin, perhaps, and we had an incredible response from patients. We had, from 7 practices, we got 120 patients coming along to a focus group to talk about where care could be improved. But we decided that wasn't the best forum, because then you got some general issues which were about education and understanding and so on. But actually what we wanted is to have focus groups within practice where they could reflect on their individual practice systems. So again, we've tested that in quite a few practices, and that again has gleaned a lot of information. It's quite labour intensive, but I mean, I think the practices have found it really quite much less threatening than they thought, and much more useful. And I think the patients who are involved on specific issues of their care, rather than representative patient participation groups, has been very productive.
Yeah, hi. Thank you for your presentation. My name is Naro Uehara from Japan. And according to my experience, in the clinical experience, experience tells me that patients as partners in safety really works and effective. But I find difficulty in convincing my colleague physicians to show that we should involve patients as partners in safety. Do you have any evidence which we can use to persuade our colleagues that we should enhance more the partnership with the patients in safety, not just information sharing, but also involve them as partners in a program or practice?
I don't have that information. I mean, you might be worth having a look at the Health Foundation review, which talks about improving safety in primary care, and see whether there's any papers round about that. I think involving safety in the acute, I think the Denmark is probably the area that's done most about involving patients in safety in the hospital setting. I think the Scottish Patient Safety Programme, the acute sector, is something that they've struggled with. So I think it's an area ripe for research.
Thank you.
Okay, well, thank you, Neil.
Okay.
Would you join me in thanking Neil for a very interesting presentation? Okay, and I'd like to now introduce Dr. Jonathan Sargent, who's a GP and also clinical director at Brighton and Hove Integrated Care Services, England.
That was a good start.
Hello. Is there any technical support to open up this presentation, please?
Not quite looking, is he? Worked before, so we'll have to wait.
Okay.
Okay. Did you? What I could do is just. I'm just to press escape. Everyone has departed. Okay. Okay. Do you think I should just turn it off and just restart it? Pardon?
Are they set up to stop them reading?
Yeah, that's do. You can't do it.
Yeah.
Please wait a minute, someone come in. I phone for your problem.
Faut attendre. J'ai cliqué, ouais. Non, pour l'instant, ça va bugger en fait. Il a planté l'ordi.
That fix that. Just tell me who we are.
Et vous pouvez envoyer quelqu'un là parce que sinon, ok, merci. Yes, yes, it's somebody from the preview.
Okay, well, as it is the graveyard shift, that maybe I might be better off just doing the presentation without the slides, and we'll see how we go. Okay? I'm Dr. Jonathan Sargent from Brighton Integrated Care. Now, I'm also a GP, so I split my time between the two. We were quite in a lucky position because we created a new organisation 4 years ago that was purely focused on engaging general practice to improve the quality of care that they deliver by providing them with feedback on what they do at the point of referral, and also by enabling general practice to take on new services in the new sort of health market in England. What I was going to talk about today is going to talk about how we've delivered integrated care. Okay, and when I mean integrated care, I mean care that's integrated between the different stakeholder organisations or providers within a health system. But also integrating, the key part of it is integrating the decision-making point where the GP makes the decision to refer on to secondary care for the extra advice to the actual delivery of seeing patients. What's been quite useful, having started an organisation from complete scratch, is that we've been coming to this conference for the past 3 years. So we've been taking the ideas and process and purpose and values into our business and being able to start it absolutely from scratch and with a team of people to try and make things work. I don't know what's going on, it's fine. So I just wanted to show of hands. Have people here heard of, have they got systems in their countries that have a point at which they have like a gateway management or a feedback system to their GPs around what they're doing when they make that referral? Is it a show of hands? Have they got gateway management, referral management? Okay, so we got a bit of a varied experience of that. Now, what happens with us is we have about 60,000 referrals that come into our service each year. So all 47 practices in Brighton send them to us. Now, they come in electronically, and then we have another peer, who's another GP who's experienced. It might be a partner, someone who's been established within the health economy, who then gives feedback immediately, real time, on what that GP is requesting. And they're commenting clearly on content, quality, and pathway selection for that particular referral. You know. Sorry, it's a bit having a noise behind. It's quite difficult. So what? All of that is based around clinical pathways. Ah, look at this! Thank God, that was getting quite difficult. So now I'm going to speak double speed. No, I'm not. I'm not. Okay, so this is integrating care, improving quality. I can now speak like this. In fact, I like walking around, so it's better. This is what I was trying to explain, which was quite difficult conceptually. Okay, so I am going to walk. Is that the key around delivering integrated services with other organisations? What we've been trialling is delivering the service around a joint pooled budget, okay, and that's key. So that everyone, when we get on board, we all know there is a finite resource for delivering particular care pathways or specialties. So in this service, we're going to talk about dermatology in particular. We run other services in musculoskeletal health, ophthalmology, gynecology, but in this particular, I'm going to use dermatology. So we have the GP consultation, and they make the referral. It goes into the triage service, as I was talking, and they have the peers giving feedback at that point. And then they also do they also speak to the patients, and they book the patient into the appropriate service in the community. And we are responsible for all of those different services. So we have a community dermatology service, we have dermatology that is going on in practices, we also have a minor surgery service, which are for doing minor procedures, and we're also responsible for the care that's going on in secondary care. So we can make sure that we get the patient to the right place to see the right clinician. Now, what underpins this is integrated clinical governance, and I'm going to just mention that a little bit later on. Now, the key about owning the whole pathway that matters to make a difference is that you can get very, very accurate, patient-specific, condition-specific data at the point at which a referral comes into your system. Okay? So we're able to build up a very clear understanding of what an individual GP's behaviour is around their knowledge base. We then use that information to focus particular interventions and supportive educational interventions to those GPs to enable them to give better care to their patients. And then we also have an opportunity to control the delivery, which I'm not going to talk about today. So let's just look at some of that data. I'll just show you. Okay, so this data, this is a GP surgery in Brighton, so about 6,000 patients. And you can see this is their referral pattern. Okay, this is what they have been referring over the past year. You can see it's the number of referrals per 1,000 patients in their practice. You can see along on the x-axis, you can see that there's different specialities, and the bar chart says how many they've been how many they've been referring. And the red line is what is that against the city mean. Now, traditionally, people have looked at these types of things, and it's usually outcome data they've had from the hospital data, so not what actually has come in and the reason for being referred, which is different. And people have said, and they say, well, I was a GP. Are they a good GP? Are they a bad GP? Does this tell you anything about them at all? And I don't think this tells you whether they're good or bad. All it does is just show you a particular pattern and where potentially you might be able to focus your attention to make a difference. So our data gets even more detailed. So this is one GP in a practice, and this is their referral pattern per actual referral reason. Okay, so on this bottom axis, you've got like psoriasis, eczema, you've got benign skin lesions, potential basal cell carcinomas, actinic keratosis, and so you get it right down to the specific referral reason. And this GP, as you can see, seems to refer a lot more basal cell carcinomas. In fact, it looks like they do, compared to the average in the whole of the area, they're referring 3 times as much. Now, that doesn't mean they're a bad GP, and it doesn't mean they're a good GP, because what it matters is what is in the referral letter. What matters is the way in which they have described their story, and the way in which, is it coherent, are they asking the right questions, and have they done the right things before they're referring them. So all this does, and when I speak with GPs and we bring this data to them and we talk to them, I say, look, don't get defensive. This is a reflective process. It's part of good medical practice, and we'll just look and see, is there anything real that we can support you with? So we did that for a year, and we were quite effective. However, what I suddenly realised was actually the real indicator of whether a GP requires further support is actually the number of times in which our GPs pick up the telephone and speak to the referring GP, because of course they've used the context of the letter. And therefore, if we look at that, and actually we've had this data for 3 years, and it's only occurred to us this year that it's particularly useful, because it's a more accurate predictor of identifying a potential educational need. And if you see on this graph, I'll just explain it to you, there's 6 GPs in the practice, same practice. You can see that it's standardized on the left side for the amount of work that they do. And the bar chart for GP4 you've got here, it says, you know, they've had 9 calls for every 100 sessions that they work around their referrals. And they are significantly above everyone else in the practice. So we can then break this down even further, down to the conditions that they're being called about. And that really, really enables us to say to the GP and have a conversation, there's some support that we can put in for you to enable you to make better quality decision making. So we do that data, and we've got different things that we do for people. So we target our resource on the people that need it, because this could be a very expensive system if you did this for absolutely everyone on absolutely everything that they did. So we use condition-specific guidelines, and we're giving immediate feedback on new evidence, so it doesn't take 17 years to get the evidence to people, as we were hearing earlier. And we give the GP access to our clinicians doing the service. And that's what's happened in England. We have separated the communication link between our consultants and our GPs. And one of the key parts of delivering good quality care is improving the communication between the person who has more knowledge and the person who needs to understand that knowledge. So what we do is we give them a relationship with our GPs with specialist interests, and we either get them to phone before and discuss the patient, or we get them to get phoned after they have made the actual referral. There's a number of other things that I'm not going to talk about. These are the other interventions that we support GPs with to make a difference. Now you'd say, what was the effect? Now this was last year's data from us. So what happened in the first year in doing this is we reduced the amount of workload coming in, actual demand, across the whole system by 28%. And patients were being managed in primary care more appropriately because they were being supported and they believed and they were engaged in our system to actually do the work. We further reduced this year from the baseline data. The data of the red line is from the years 9-10, and then from 8-9, and then from years 9-10 is the blue data, and that's the actual demand coming in per week. And this year we've got further reduced by about another 14%. I don't think we're going to be able to reduce much further, to be honest. I think we have made an impact that is going to fluctuate over the next year. So that's one component of trying to deliver integrated care, is making sure you have some control of what's coming in the front end so that you can leave your clinicians to get on to be dealing with demand that's possible. Okay, the actual structure isn't important here. So what I was going to talk about is integrated care partnerships. And we spend a lot of time managing the politics. 3 directors in our organisation spend a lot of time trying to manage our projects going through bigger organisations, because everyone has different political agendas or pressures on their work that will stop them going into the change process. And we say we're going to integrate. Now, President Eisenhower said integration was the alignment of economic and political systems were essential for a sustainable Europe. You can actually say that you need to align the financial incentives and the finances for the whole system, and also the local politics with the clinicians and also the managers and the GPs, to ensure that this is just a sustainable solution. And we're saying integrate because that's going to make it a lot better. However, the definition I was looking on the internet, I was thinking, what's the definition of disintegration? Well, that's the natural or induced transformation of an atomic nucleus from a more massive or less massive configuration by the emission of particles or radiation. So really, what the hospital is experiencing is disintegration, because they're the induced transformation of an NHS trust from a more massive to a less massive configuration by the emission of services. Because we're moving stuff out. They're losing money. The consultants are losing their domain. They're losing what they believe in, what they've built up in, their ambition. And therefore we live in that paradox. And that is the biggest bit of political tension that we have to try and make this successful. Now in BICS we have different contractual models, which is interesting. So we experiment where we are the lead contractor and the secondary care provider is a subcontractor in dermatology, but in musculoskeletal health, we are the other way around. So we are the subcontractor to them. Now, having those two things running at the same time is actually quite useful. So if you end up with having problems with payment, finance, progress, pathway development in one of them, the behaviours, they equal each other out, because we say, actually, we've got to carry on doing that. And if someone says, I'm not going to do that, and you're subcontracted to us, you can't ever go back to that kind of behaviour. In England, we tender lots of services. I don't know what it's like in other countries. And actually, I can see a benefit to that. And the reason being is because everyone has lost before you've gone into the tender. And then when you go into the tender, you go in and you form your partnerships, and we've just launching a new mental health partnership with 7 practices, a new trust, and also 2 voluntary sector organisations, because we won the tender together. Now, the actual main person who lost in that was the acute trust. However, by tendering, we all get into a win-win relationship, and I think that's very important. This is something else we picked up from here a couple of years ago. I don't know if you know the sort of definition framework for quality by the US Institute of Medicine. And we came here 2 years ago and we looked at making sure that we took this back and we integrated this framework of effectiveness, safety, person-centered, timely, efficient and equitable framework into everything that we did. All our executive team meetings are based around this, so we base what we do around quality. So if we focus on what we're doing on quality, we're more likely to deliver it. We also ensure that all our integrated governance policies are all based around this framework. And one of the key parts was, when we get doing our integrated governance, was that we make the people who actually do the work and actually make a difference to our service are the clinical quality group. So they work with this framework, so they do take into account time and cost, but also about access and also complaints and errors, etc. But we enable that clinical quality group to be effective. We train them in PDSA cycles and we allow them to make change, and if they want to change something, they can change something the following 2 weeks. And that is the reason that this works, is because we've taken away some of the political problems around delivering these integrated services and given it back to the clinicians so they can continue to deliver quality. And that's what I've got to say.
Thank you, John. Many apologies for the breakdown system. Have we got any questions for John at this stage? We've got a few minutes before coffee.
I'm Kate Adams from London. I was interested because I know nationally there's been quite a move against, politically there's been the RCGP saying we don't want these referral centres, the BMA saying that's our trade union, we don't want these referral centres, and GP's very protective. And I know you've discussed having a kind of sweetener of education, but can you describe that system in more detail, how you won hearts and minds? Or was it just people had no choice and you had good clinical leadership? What was it behind that you got the GPs to all do this?
So I was going to put up slides of the banners of the BMA saying right to refer. You know, we all have a right and we shouldn't. All these referral management is a terrible thing. And the right, and administrative-led referral management doesn't work. It has no clinical engagement, and it has, it doesn't have a place that's going to improve patient care. When we set this up, we went through a lot of engagement with our GP community, and as you'd expect, we had people who were absolutely up for doing that, and also we had a few people who weren't. And we still have those people who lagged behind, and they have come on board with it. And it was about showing them that actually what we were doing is facilitating. And we're facilitating the journey of the patient so that they're getting into the right place. And we're enabling people to use good quality data that is quite difficult to challenge to help them improve from an educational perspective. And if you take, the other part that we do is we work a lot with practices, and we go into practices, we send our patient care advisors into practice to solve some of the problems. And a lot of the problems about using things like Choose and Book and things like that are because the secretaries don't know how to use it. And we just went and solved those problems for them, and so the GPs could actually get a better system.
Hi, my name's Kat Chatfield. I'm a GP in London. Thank you for a really interesting example of a structurally and managerially integrated care pathway. In what way has this had an impact on the patient experience? For example, once a patient goes through this fantastic pathway to secondary care, how has that changed their experience?
So what we've done with the new pathways, where we've changed the delivery and the provider part, is we've put in patient surveys for every single person, so they could do immediate feedback. We basically set up the clinics so that all of our appointments are longer. They're more educational. They make sure that everyone gets leaflets, and we manage that. So where we set, I haven't talked about the provision really. Where we set the provision up, it was always based around basically having more of an educational experience for patients. Our patient satisfaction surveys are excellent, which is great from our perspective.
We have any more questions for John? Okay.
Thanks, John. Andrew Jones, sessional GP in Surrey. I mean, from my perspective, I completely buy into better data about the quality of my referrals and using that to educate me. I completely get that there are things that I'm bad at referring on. So I have no problem with that. And I just wondered whether you'd thought about sort of point of care tools which will help the referral decision making before it even gets to you. So you might even actually be able to reduce the demand on your services.
Well, since your talk, obviously, Andrew, about an hour ago, you could see the benefit of having that. We were just talking about that just after, weren't we? And it was about how do we get a GP to know they need to look for something when they don't know, and that's the crux that hasn't really been solved, because we can have lots of our tools there, but if we don't know what we're doing, then it's that's the problem, to know when to turn it on.
Okay, well, if there are no further... you got a question? Okay, we've got time for one more.
Hi, I have one quick question. In the United States, we did some bad things back a ways regarding referral management and HMOs and all that. Do you actually tell patients they can't go?
No.
So they can still go, you're just managing.
No, okay. So what we do is we will talk with the GP, and we won't stop a referral unless there's an agreement between us. Okay. So what we're doing is we create a clinical conversation between the triager and the GP. And I think we've only had 2 cases where GPs have said, actually, no, I want this has to go through. It just gets escalated up, and myself or Peter's here will have those conversations, and they're difficult conversations. But people have gone back, they've reflected, and they've gone and said, okay, well, we'll make that change, or we'll do that extra intervention before we send them. So far, we haven't done that. And when we agreed to do this, we always said, if you feel the patient has to go, and absolutely, even after we've had a conversation with you, we'll let that happen.
Thank you very much, both of you, for the presentation. My name is David Moores. I'm a family doctor in Edmonton, Alberta. We may have a peculiarity that you may not face in the UK. In the consultation referral process in Edmonton, we have discovered that most of our consultants have become so subspecialized, and when they engage in developing pathways, usually without us GPs being part of it, it's just a process of saying what they will see and what they won't see. So we have gastroenterologists who don't do livers. We have urologists who don't do bladders. How does the work that you've done, how might we borrow and steal from you to maybe address this issue? Maybe it's not a problem that you have in the UK.
I think it's absolutely a problem that we have in the UK, and it's one of the reasons our system is so expensive. And I think it was Nigel Edwards saying yesterday we need a generalist in the hospital again, because that's what's going to make a difference. Yeah, please. Yeah.
I'm Peter Devlin, and I'm Jonathan's co-clinical director. It's absolutely the strength of collecting demand data around conditions, around what it is that the doctor is referring for in the first place. And then in a commissioning environment, where it's a transactional arrangement between a referring doctor and a specialist, if a specialist doesn't want to provide a service, then we'll go and find somebody who does want to provide that service. So it's understanding what the demand is, then that tells you what do you need to go out and provide. And part of what we do, and one of the reasons to pick up somebody else's question around getting engagement, was the recognition from a lot of primary care colleagues that the complexity of the services that we could now refer into, it was no longer, you referred to the local general physician for all things medical and the local general surgeon. The complexity was such that it was really difficult for people to navigate all the options that were available, and to have an expert resource that centralizes that knowledge, then people can feel confident, then we can make the decision around where the patient should most appropriately go.